Okay. So the topic of my lecture is the neuromuscular scoliosis, and I will expose you our technique our surgical technique for treatment of this population of patients. As you know, the neuromuscular scoliosis is due to spinal deformities. The spinal deformities are due to muscle disorders, to muscle weakness or retraction, and to an imbalance of the trunk.
Dr. Miladi,
yeah.
Please be closer to the microphone. Nothing we can hear you.
Okay. So I go on in my lecture. These deformities start very soon and require an early treatment. It's okay. You hear me or not?
A little better, but is too quiet.
I am sorry, but I don't know how to change the microphone. Have you an advice?
Just a moment.
Yes.
Give me access to your computer.
Yes.
Just a moment.
Yeah, yes. Now it is better.
Now it's excellent. Excellent.
Sorry. Yes, I forgot that the mouse was far.
Okay. Excellent. Continue, please.
Yes. Sorry for my bad English. It is very poor. Okay. So these deformities require an early treatment, and the traditional treatment associates bracing first and after arthrodesis at puberty. The conservative treatment is efficient at the beginning, but it is unable to stop the curve progression, and it is awaiting treatment for surgery, before surgery. And the arthrodesis provide a high rate of complications till 60% or more in the literature, and especially hemorrhagic and infectious complications. And the traditional growing rods are more efficient than conservative treatment in this population, but these techniques provide many complications due to the difficulties to fix. Sorry, don't touch my screen, please. And due to poor general status of the patient and some mistakes from the surgeon. That's why we developed another alternative for surgical treatment in this pathology, in neuromuscular scoliosis, that is based on bipolar strong fixation, as you can see on the X-ray. Proximally, we fix the construct with with hooks, with the hooks close, 2 hooks close, that is very stable fixation. And distally, we use the iliosacral screw as pelvic fixation. That is a good and reliable technique in this population. So we realize a telescopic frame. The long rod, the red long rod, can slide up when we realize rod lengthening. And we perform this surgery by a minimally invasive approach, as you can see in this picture. You have to know that the most important thing in our mind is the iliosacral pelvic fixation. That is the foundation of this technique. And you can see here the entry point of the screw that goes through iliac wing and enter in the sacrum. And here you can see the way and the path of the screw. It is inside the bone from the start at the end. That's why there is a very strong and stable fixation. We operate this patient under intraoperative traction and neuro monitoring. We start with distal medial incision, and we go through the muscle by Wilsey approach to look for the iliosacral lumbosacral joint, and we developed some specific ancillary to insert the screw percutaneously. We use at first a dedicated osteotome to create recessus to insert the iliosacral connector, as you can see, and after we use a guide that help us to insert the screw percutaneously. As you can see here, the guide create a mark on the skin. We perform a little counter-incision for introduction of the screw, and we prepare the screw path with the hole inside the bone till the sacrum. And after we use a cannulated tap. We insert a pin using a musical hammer to check the length of the screw, and after we can read the length of the screw on the measurer. After we remove the guide and the pin stay in place to insert the screw percutaneously, thanks to cannulated screwdriver. And after we lock the iliosacral screw inside the connector. We perform the same thing in the other side, and proximally we perform a medial incision. We go subperiostally to expose the thoracic lamina, and we insert the hooks without preparation to preserve all bone capital and to have a good proximal fixation. Here the pedicular hooks that is inserted without preparation to the other side, and after we prepare the rods bending, we can simulate the construct before rod insertion, and after we insert the rod in subfascial way. And we introduce first the rod inside the hooks, and we perform hooks compression on the claws before tightening of the nuts. After, we insert a domino before the distal short rod insertion. The short rod is inserted inside the iliosacral connector, and we insert the rod in the opposite side. And after, we can perform some distraction or compression maneuver to obtain correction before closing. And as you can see here, the size of the incision. We recommend for the beginners to use the fluoroscopic or navigation control to avoid some misplacement of the screws. And our technique is strong enough to avoid the need of brace or cast postoperatively, and the patient are sitting down or standing up a few days after surgery. The advantage of the telescopic construct, the first is the safety. It is a safe construct because we obtain a gradual correction in opposition with the arthrodesis, where we look to obtain an immediate maximal correction, and that may expose the patient for neurologic complication. With this technique, we go step by step, and there is no need to obtain a maximum of correction at the first surgery. We can perform some rod lengthening on demand to obtain a progressive correction and to avoid complication. And this construct is very efficient, and it increases the amount of correction. As you can see here in this case, the quantity of correction that we obtained, especially for the pelvic obliquity correction, we never obtained this amount of correction before with arthrodesis. And thanks to gradual correction and the powerful behavior of this technique, we can obtain better correction than with arthrodesis, as you can see. And another advantage of this technique, it is less invasive, as I said, and that we have less complication since we use this technique, and this technique is less expensive thanks to avoidance of the brace needing and the less ICU and hospital stay, and thanks to less complication to treat. We published our first series, the first 100 cases in 2018. The mean age was 11 years and 6. The mean follow-up was 3 years. And we had in this first series 26% complication. This number is relatively high. It is certainly due to our learning curve at the beginning. We had 16 infections and 12 mechanical complications with only one rod fracture. Here, a first case of an SMA case, 10 years old. Here, the X-ray after initial surgery, and 4 years later, after one rod lengthening, you can see the result is the lateral view and the clinical picture before surgery, 2 years after surgery, and 4 years after. You can see the results and the improvement of the general condition of this patient thanks to this less invasive technique. Here you can see the lateral picture. Another cases of Hirurgija syndrome, 11 years old, with tracheostomy and rigid curve. We operated her with this technique, and you can see here the initial picture after surgery, and here 2 years later with one rod lengthening procedure, and you can see here the lateral view and the clinical status of the girl before surgery, here 1 year later, and here you can see 3 years later the change of the general condition of this patient. We never see this improvement of general status after arthrodesis when we performed arthrodesis 20 years ago. So to avoid repeated surgery, we developed a new self-expanding rod that slide in only one direction passively. It operates with a mechanical principle, and there are two sizes of lengthening reserve. Here, the notched part of the rod, as you can see, 50 or 80 millimeters reserve. This rod can expand passively by daily activity or natural growth of the patient, or actively thanks to axial traction that can be done by the patient himself if he is able to perform auto-elongation session. The traction can be performed by parents, physiotherapists, surgeon. It is an open technique, and the traction can be done on demand. Here, a first case, an SMA case, 7 years old. The X-ray after initial surgery, 6 months after surgery, and 1 year later, you can see the expansion of the rod here without new surgery. Here the lateral view. Here the initial status of the boy before surgery. Here after initial surgery, 6 months after surgery, and 1 year later, you can see the improvement of the general status of the patient and his functional status with better balance on sitting position. You can see here the lateral view and the correction of the initial kyphosis. Another SMA case, 11 years old girl. Here you can see the initial picture, the X-ray after surgery, and 2 years later, you can observe here the spontaneous expansion of the rods, and here you can observe the spontaneous improvement of the residual pelvic obliquity. We never see this phenomenon before with the traditional technique, and especially with arthrodesis. Here the lateral view. Here you can see the clinical picture of the girl 2 years after surgery with the improvement of her general status. And another case of SMA, 11 years old. Here the first X-ray after surgery, and here 2 years later, and we can observe the spontaneous rod expansion. And here you can see the improvement of the pelvic obliquity and even the residual deformity. Here you can see the lateral view, the initial picture 1 year later, and 2 years later. Here you can see the lateral view. The last case, it is a CP case, 10 years old, with this huge deformity. Here you can see the X-ray after initial surgery, and here 2 years later you can observe the spontaneous expansion of the rods and the improvement of the thoracic shape and the size of the trunk. You can see here the lateral view. In the initial picture, the patient was enabled to sit down, and you can see here the improvement of this general and functional status. Thank you for your attention.
Thank you for this very presentation. I would like ask someone if has some question to ask you something. It's very impressive.
Yes.
I would have a question, another one from Belgrade, if I may.
Of course.
Thank you. Thank you, Dr. Miladi. It was really, the results are extremely impressive. And we see now in scoliosis surgery, everybody is trying to avoid fusion. Even in idiopathic curves, there are many new instruments trying to avoid fusion. And I'm very eager to see where this is going to take us. But with this implant, it's kind of a load sharing implant. And what do you think will happen without fusion with such a long construct during the years? You're not taking it out. Did you have any rod breakages or mechanical complications of that sort? Thank you.
Yes, a good question. Yes, we had about 3% of rod fracture at the beginning. And the most frequent rod fracture was seen in walking patients fixed to the pelvis. That's why we improved progressively our construct, and for risky patients, for walking patients, now we perform a reinforced construct with two long rods on each side. So the reinforced construct contain four long rods. And for the other question about the evolution of the spine without fusion, now we have 10 years and 3 months follow-up after the first case, and we noted in the first cases a progressive stiffening of the spine and even spontaneous fusion in the lumbar area when we reoperated the patient for rod lengthening. That proof that the evolution go to a progressive stiffening and ankylosis of the spine, and we think that after 8 years or 10 years the spine will be completely rigid, and we can consider that our technique is a delayed fusion, a delayed arthrodesis, and this technique allow us to improve the residual deformity and to obtain better results than with arthrodesis, where the result is immediate. If the correction is incomplete with arthrodesis, you can't do anything. And sometimes you can expose the patient for neurologic complication because you try to obtain the maximum of correction when you perform arthrodesis. This element, this criteria is deleted with this technique. There is no need to obtain maximal correction at initial surgery. That's why we have very, very, very low neurologic risk with this technique. And the final result in our series is better than with arthrodesis, and especially for pelvic obliquity correction. In some cases, we obtained an hypercorrection of very important pelvic obliquity, 60 degrees, 65 degrees initial pelvic obliquity. And at the final result, we obtained an hypercorrection. It was incredible, and we never imagined that before trying this technique.
Thank you so much.
Thank you.
You're welcome.
Dr. Ventura, do you have some question like a moderator? Something to comment? We can hear you. You have to unmute your microphone.
It's okay now? Can you hear me?
No, it's okay. Okay.
Well, I think that Dr. Miladi has pushed forward a new technique, which is a new philosophy. We have been using pedicle screws at all levels. We have been putting bone graft. We have been very proud to achieve a very, very strong fusion, spine fusions. But I think that the bipolar concept is completely different. Even you cannot believe at the beginning that these things can go so easy, because usually in neuromuscular scoliosis there is no easy curves and there is no strong boy. All the children are very fragile, are very sick, and the great advantages is that it's not an aggressive technique. This is what I have been thinking about, because in my hospital we have been treating spinal muscular atrophy type 2 till from the 80s, 90s, from the 90s till now. And we have been a referent hospital for this pathology. And we have achieved very nice correction, but patients have paid a very high price. So I think this technique, for me, it's unbelievable. It's a new concept that we have to adopt, especially for neuromuscular scoliosis. But even we can apply in idiopathic as well. We have done some cases with this technique, minimal invasive technique, and the results are similar. I used to correct the deformity, the idiopathic adolescents deformities, by apical vertebral derotation. That means that we put some tube connectors to the screw, and we push down the rib ham on the convex side, and we try to raise the concave side. But Dr. Miladi applied distraction, and with this distraction, you can reduce the rib ham, you can balance very well the spine, and I think that you don't need to open to approach all the spine and to do so aggressive surgery. So I think the key point is the best solution for the deformity in very fragile and very sick children is the less aggressive. And I think that we have to recognize that Dr. Miladi has changed all our minds, surely.
Time for comments? Dr. Miladi.
Thank you very much, Norberto. Yes, I have just a comment that I would like to add. I worked with my boss, Jean Dubousset, at Saint Vincent de Paul Hospital, and we were the referent hospital in neuromuscular scoliosis in France. and we experienced some terrible complications with some dystrophic muscular cases, because the arthrodesis was very aggressive for this patient, and we had some difficulties to manage this patient. And our anesthesiologist team said us, for some patient, we are not agree for the surgical indication for this patient. The risk is too high relatively to benefits. With this technique, minimally invasive, since we perform this technique, we don't see any refuse of the anesthesiologist of surgery, because this surgery is less aggressive, and even the patient is very thin, with 15 kilograms body weight only, and with bad respiratory function, with only 15% vital capacity. It is possible to realize this technique, and our team is convinced that some patients were in very difficult situation, and the death was not too long to arrive. And with this technique, salvage solution for them. Sorry for my
Okay. Okay, thank you.
You're welcome.
Anyone else?
I have another question. Have you thought about applying this method to early onset scoliosis of idiopathic origin? Have you done it? I heard Dr. Ventura mentioned it. Did you do it without the pelvic fixation, but maybe the same principle?
Absolutely, but you have to know that pelvic fixation is mainly for neuromuscular scoliosis, or some syndromic cases. Of course, we performed some pelvic fixation for syndromic or early onset scoliosis, very huge and very unbalanced, and the result was so impressive than with neuromuscular cases. Perhaps in another opportunity, I can show you some cases of early onset scoliosis that we treated with this method, and we hope that with the new self-expanding rod, we can offer a better care for these difficult cases at a younger age, because the surgery is not well accepted now by parents and by some practitioners, because the traditional techniques are a little bit aggressive, and there is many complications, and there is many unwanted, unplanned surgeries, and we try to avoid the disadvantages of early surgery, and we hope that the new self-expanding rod can help us to offer our care for younger patients, to obtain better results, and to avoid difficulties when the deformity is very progressive and the traditional technique are unable to manage them.
Also, I think it's very impressive that you eliminated the patient compliance in need to doing some special exercises like we see in some ratchet systems, the unilateral growing around ratchet. You do not need any specific exercises to elongate the rods, right? Just growth and passive exercises after operation.
Yes, for soft curves and the reducible curve, there is no need of special exercises. But for rigid curve, you can help the rod expansion by traction or auto elongation. I ask the child to jump with cord or on the plan that I forgot the
elastic bed.
Yeah.
Trampoline.
Yes, and I saw some
Jumping.
rapid expansion of the rod after exercise, and all other techniques of external rod for huge deformity correction can be used, like Stagnara cast, like halogravity cast after rod insertion, halogravity technique, sorry, and even other technique like Elizarov frame for distraction that can help the rod expansion and that can provide us good result thanks to viscoelastic relaxation of soft tissue and the progressive correction of these deformities. It is the exactly opposite way to the vertebrectomies and osteotomies that is used by other surgeons, and that is very aggressive with high rate of neurologic and vital risk complications.
Thank you so much. It's remarkable.